We're paediatric hormone doctors, aren't we, Claire? And we see young people with hormone problems around the northeast, most of them based in, well, many based in Newcastle. But I think it's fair to say that a substantial proportion of the young people we see have thyroid problems. And the British Thyroid Foundation have provided us with a list of questions. And I thought what we could do is maybe work our way through these questions as best we can. What would you say to a young person who came to your clinic, maybe with their mum and dad, who said to you, "Doc, what about these thyroid function tests? What do these? What is it you're actually measuring when you take my blood sample?" What would you say to them?
Yeah, so often this is the first sort of introduction to thyroid function tests that they've had, isn't it? They come from the GP referred with these tests, and I try and break it down into the TSH, so the thyroid stimulating hormone, which is produced in the brain, and that tells the thyroid to function. And then you've got your free T4 levels, which are the most commonly measured in GP land. And I tend to sort of say, if your TSH is high, it's the analogy that I think you first used about the horse and the jockey, and it's a bit like the jockey having to whip the horse really hard. So the TSH is having to work really hard to produce that thyroxine, whereas if your TSH is low, the horse is galloping away and you're not having to whip that horse at all. So it tends to be, those are the two patterns that we see, don't we? We either see the TSH being high and the thyroid hormones themselves are low, or the TSH is low or suppressed, as we often call it, and the free T4 level is too high. That's really what we normally see, isn't it?
So using my wonderful horse and jockey analogy, if you're underactive, then the jockey's whipping the horse like mad, but the horse is going slowly. And if the young person has an overactive thyroid gland, the horse is galloping and the jockey sat there doing nothing. So the TSH level would be low. Whereas in the first scenario, when the jockey is whipping the horse, in the context of hypothyroidism, you'll have a high TSH and a low free T4. Right. Okay.
So, and those are the most common thyroid function tests that we see, aren't they? I mean, very occasionally, you can get a sort of a slightly different picture, can't you? Where the TSH, because the problem is from the brain, so secondary hypothyroidism, then you don't get that jockey able to whip the horse. So the TSH stays low, even though the free T4 is low. But that's much rarer, isn't it?
Yeah. So if I was to, I'm into this analogy in a big way, as you probably noticed, Claire. So just to recap for people listening in, then if you're hypothyroid, the TSH is high, free T4 is low, so the jockey is whipping, but the horse isn't moving. In the context of overactivity, typically that's the TSH low, thyroid hormone levels high, that's the jockey sat there doing nothing, but the horse is galloping.
Yep. And
then the final scenario that you talked about was the secondary hypothyroidism, which is where you have a lowish TSH because the pituitary gland isn't working in the normal way, and a low T4. And going back to horse and jockey, that's a jockey sat there on a horse, neither of which are doing a great deal.
Yeah, absolutely.
If you were in clinic seeing a family for the first time, just say for the sake of argument it was a young lady or a young man and her or his parents, and they asked you that question, what would you say to them?
Well, I think firstly, the reason they've been referred to clinic is probably because there is a problem with their thyroid function tests, and often that's as much as somebody knows to start with. But the way we sort of tend to split it up, isn't it, is that we tend to talk about the thyroid stimulating hormone results, the TSH, which is the brain signal, and then you've got the free T4 levels, which are the amount of free hormone that's produced at the thyroid gland level. And it's really split, isn't it, into whether your TSH is high or your TSH is low, and those are the two main referrals we get to clinic, aren't they?
I think that's fair to say. Yeah, I think that's right. So if your TSH is high, what does that mean?
Well, that really tells us that that person's thyroid isn't working as well as they should be, because they're having to work very hard. You often use the analogy a bit like a horse and a rider with a jockey, don't you? And the whip. So the TSH, you're having to whip the horse harder to get going. So if your TSH is high, it's a suggestion that your thyroid isn't producing that free T4 the way it should be, that you're having to work really hard. And on the flip side of that, if you've got an overactive thyroid, your TSH is low, isn't it? Because you're not having to whip that horse at all.
And the horse is galloping along at increased speed, yeah. So it's not a bad analogy, is it? I mean, it's got some limitations, but I think it's quite useful, isn't it, to think of it like that. And I guess the main things we look at, which is what you've said already, or the main parameters we measure are the TSH, which is the brain signal, and the free T4. I mention that because there's another question here, which is about free T3 or T3. And it says, why is T3 not routinely checked? And before today, I was thinking a little bit about this. So,
I mean, we do check it in some instances, don't we? We tend to check it, don't we, if the thyroid's overactive, because it can be, a useful marker then. But we very rarely, it's not a useful signal for us if it's an underactive thyroid that somebody has. We tend to just rely on the free T4 at that point, don't we?
I've got another analogy for you with that in mind, actually, Claire, because I think I totally agree with you. I think the T3 in the context of thyroid gland overactivity is very, very handy, very, very useful. It tells you important information. I suppose the problem with T3 in people who are underactive is that it doesn't really give you a proper insight into the status of the thyroid gland. And my analogy was thinking about going past the shop window, let's say for the sake of argument, the baker's shop window.
And I think I've heard this one.
You've not heard this one before, but and in some respects, what you want to know is how good the bakery is. You want to know whether the bakery is thriving, and you look in the shop window, and sometimes there are lots and lots of cakes there, and whilst you might come to the impression that everything is fine, it's not really measuring what's going on behind the scenes. And everybody could have pulled the stops out and produced this great show in the window. But in reality, things behind the scenes might not be all well. And it's a bit like that, isn't it, in people who are underactive? It's almost as if the thyroid gland pulls all the stops out and you see sometimes a normal T3, when in reality, the thyroid gland is struggling and is not in the best health at all. So you can think, oh, everything's fine when it isn't. But it also works around the other way as well. Continuing with the same analogy, you can go along and the shop can be empty. But that's not telling you what's happening behind the scenes. It might be empty because actually it's a Sunday and everything's being sold. But the reality is that the bakery is absolutely fine. And so free T3 in the context of I guess, the patients who are underactive, it can be a bit misleading, can't it? Is that fair to say?
Yeah, I think that's fair to say. I mean, often we can actually just do what we need to really with TSH as a marker, isn't it? All I was thinking was we should probably mention there that sometimes TSH isn't that useful in rare cases, isn't it? But that's
and I think that's a good point, because I think as is the case with so many aspects of medicine, as a general rule, free T3 in underactive patients is not a really big piece of the pie, but there are some rare scenarios where it can be a useful piece of
but what I was sort of saying there is that TSH, sometimes a GP just refers in having just done a TSH level, and almost 95% of the time that's fine, isn't it? But sometimes we need some extra information.
Yeah, that's quite so.
In secondary thyroid problems, that's what I was just thinking about.
Right, yeah. And so basically T3 really handy if you're overactive, not quite so handy if you're underactive. I suppose the final, sort of parting shot with that is to say that so often when you're poorly, your free T3 levels will be low. Again, your thyroid is fine. It's just that the thyroid hormone levels change as a consequence of the illness, and it's not the underlying cause. And I know we get
a lot of phone calls about that, don't we?
Yeah, lots of phone calls about people who've got a low free T3, which is a feature of their illness, and when their illness gets better, the free T3 comes up again. Another question, which I think a lot of people will have asked at some stage, is why do I sometimes feel tired despite all my thyroid levels being normal. If somebody asked you that, if it came to clinic, let's say it was a teenager came to clinic and said, Doc, Claire, why is it I still feel shattered, but you've told me today my thyroid hormone levels are fine.
We get that a lot, don't we? I think we get a lot of GPs asking for advice in between appointments and things, don't we, about people who are, in the thyroid clinic. And I think the difficult thing is that, the thyroid gland controls so many different systems that there can be so many potential signs and symptoms, can't there, when you look on, websites or the information that we give out and things, that it can be responsible for pretty much anything you can feel. But I think the important thing to remember here is that if your thyroid hormone levels are normal, then the chances are it's probably not your thyroid that's causing you to feel tired and unwell. And often we end up doing other blood tests and things and asking, doing other clinical examination, asking other questions to try and get to the bottom of what's going on, because it is unlikely to be your thyroid. Particularly in, for example, a teenage girl, we'd always want to ask, about their diet, about, exercise levels, anything else going on, their periods, are they anemic? Lots and lots of different causes of these things, which can be quite tricky to unpick. But I think, not saying that we get it perfect all the time with our thyroid medication, but if somebody's taking their medication and their levels are okay, I think it probably would be a signal to start looking elsewhere for those signs and symptoms. Do you think that's fair?
I think that's fair. And I suppose once or twice you come across late night Xbox sessions until 3 a.m, don't you? And so sometimes I guess it's just inquiring, I suppose, about people's sleep pattern.
Yeah.
Where they're getting can be as simple as that sometimes, can't it?
Whether something else is going on at home, at school, all these different aspects, yeah.
This is an interesting one. It says, I have autoimmune thyroid disease. Is there anything I can do to reduce my antibody levels? So if you were posed that question by someone in clinic, what would you say to them?
That's a tricky one. I might deflect it back to you in a minute, but I guess it partly depends, doesn't it, on what antibody it is and what the cause of that autoimmune thyroid problem is. Because I think in the patients we see with Graves' disease, which is obviously autoantibody related, I think that taking your medication well, that you've prescribed, doing all the other things right that we've been talking about, getting good sleep, getting some exercise, healthy diet, all those things are really important to help try and bring your antibody levels down. But I think there's always a lot that you read, isn't there, about sort of faddy diets and supplements and things, and I'm not sure there's really any evidence particularly for anything per se to bring your antibody levels down. I mean, I know there was some research a while ago, wasn't there, about selenium and vitamin D and things, and they may make a tiny little bit of a difference, but I think people can get very caught up on, trying to bring their antibody levels down, whereas actually, just trying to be healthy and take the medication is probably just as important. Is that?
Yeah, I think that's really wise words, Claire. That would be my take on it as well. I think that whilst, you mentioned selenium and vitamin D, and people have got excited, haven't they? But the research hasn't really been consistent in terms of showing a substantial effect that's worth having. So yeah, I totally agree with what you're saying. In many respects, I suppose there are other bigger pieces of pie again, I guess, the just looking after yourself in a more general sense from a dietary, sleep perspective, exercise perspective.
I think the other thing to mention there maybe is I get a lot of patients coming into clinic, quite fixated on their antibody levels, particularly with an underactive thyroid, and we don't tend to measure them routinely, do we, from, baseline, because actually the antibody level itself isn't necessarily going to tell us what we need to do to the medication or how that person's feeling. So it's a little bit more linked, isn't it, with TRABs in Graves' disease. But, often I think, seeing a tiny fall or a tiny increase in your antibody level isn't actually a big deal.
Yeah, that's very true. I guess you mentioned TRAB, which are thyroid receptor antibodies, and they're the characteristic antibodies of Graves' disease. And you did mention the fact that those levels can be quite handy. So if I had Graves' disease, thyroid gland overactivity with a suppressed TSH and high thyroid hormone levels, how would the TRAB guide you as a doctor when it comes to this, deciding about my treatment?
Well, I think we can just use it in addition to other things, can't we, as a sort of prognostic factor. So, we know that people who have a very high TRAb level at, time of diagnosis are probably less likely to go naturally into remission and probably going to need, a more intensive treatment course, aren't they? But equally, those ones with a lower TRAb and the ones whose TRAb level, drops really nicely on starting treatment, we can probably be a little bit more optimistic about their treatment course. I mean, I don't think we can necessarily, it'd be great if we could, but we can't say, yeah, your TRAb level at diagnosis is that, therefore you will go into remission. But I think we can be guided, can't we, by how they respond.
So it provides you with a bit of a steer, basically.
Okay. Yeah, that's what you've told me anyway. So.
Yeah. So if I had Graves' disease and my TRAb levels were high and now they're low, then it might be worth, is it worth thinking about stopping medicine?
Yeah, I mean, I think if you had been on, your carbimazole for a couple of years, it was at a good time in terms of other life events. I certainly wouldn't want to be fiddling with your regimen just before your GCSEs or something. But if it was a good time and you were keen to have a go and, everything else was sort of lined up, then if you had low TRAbs, I'd be much more inclined to say, yep, that's a good idea, rather than if you had really high TRAbs, were on a really high dose of carbimazole and your bloods were all over the place, for example.
I guess thinking of the young people we see in clinic, most people with autoimmune thyroid disease have autoimmune thyroid disease and nothing else. But there are a few patients who have celiac disease, a few patients who may have pernicious anemia, for example. Yeah. So I suppose it doesn't. A
couple of Addison's don't.
Addison's as well. That's a good point. So I suppose if you're on thyroxine, you've got normal thyroid function tests, and you don't feel right, then it's important for health professionals to think about these other conditions.
Yeah, although they're rare, they're definitely at a slightly increased risk, aren't they? So it's important to remind whoever you're seeing if you.
So if you have a tummy upset, or if you're losing weight, then I guess you think of celiac disease. If you're feeling sick, for example, then you think of things like Addison's. But actually, in any one individual, they're quite uncommon, aren't they? Is my autoimmune thyroid disease genetic? What would you say?
Yeah, so we know that there's a definite genetic predisposition, don't we? And we think it's not entirely clear, is it? But there's probably lots of different genes susceptible for it, and a combination of those will put you definitely more at risk. I mean, I think it's up to sort of 90-95% potentially, isn't it?
Yeah, it's certainly
depending on which autoimmune condition it is. But.
So it does tend to run in families, but as a consequence of that, I guess, doesn't it? But just because your mum or sibling has got thyroid problems, autoimmune thyroid problems, doesn't mean that you're going to get them. Focusing a little bit more on the overactivity, another question here is, what are the long-term effects of being on carbimazole? And there's been a shift, hasn't there, really, in recent times towards treating people with carbimazole for longer. And I know we always think about carbimazole as being a very safe medicine in most individuals. It does have some side effects, but those side effects tend to be earlier on. And if you're on carbimazole for the first few months and are tolerating it well, then it's very unlikely to cause problems. And I think in the long term it is a safe medicine. But I know you're very, very, very keen to emphasise the importance of checking for blood counts if you get a sore throat, even if you've been on carbimazole for 3, 4, 5 years. But
yeah, if you've got a high temperature or new mouth ulcers or sore throat, it's always best to get checked, isn't it? I mean, it's more likely at the beginning, as you say, when you're on a high dose, but we have seen the odd person, haven't we, later on down the line, so it's just worth remembering.
But how about, though, Claire, then this is a really tricky one. What about on a Saturday night, if you sat down to watch telly and you know there's a 5-hour wait in A&E, what would you do then in terms of getting your full blood count checked?
I guess it depends how poorly that person is. If they're not very poorly, then you can make a judgment call, can't you, whether it can wait till the morning, which I think would be entirely reasonable. But if they're very poorly, they probably need to be seen anyway. So.
Right. And accept the consequences. Yeah, the 5-hour wait. I mean, I think it's worth talking a little bit more about carbimazole and Graves' disease, Claire, because if there's one condition that is a real challenge to manage in my practice, it's Graves' disease. And that's because none of the treatments are head and shoulders above the other, if you see what I mean. And I know that's one reason why you are very keen to develop new therapies for Graves' disease.
Yeah, we haven't had anything new for years and years and years, have we? It's the same that people were doing 40 years ago, unfortunately.
I guess what's new in the world of Graves' disease? Well, I would say that a lot of people are talking about is longer term treatment with carbimazole, which I think is probably making a statement about its safety, and the fact that although people do get side effects such as rashes, they tend to settle with time. The most severe side effect we worry about, which is a low white cell count, that tends to occur early on, and with good safety netting, that should be picked up early. So if there's been a shift, then it has been, I guess, a recognition that long-term anti-thyroid drug treatment with carbimazole is okay.
Yeah.
And a bit like going to Primark, a bit like going down the supermarket, you go in and you choose a treatment that is right for you. And if somebody wants to take carbimazole for years during their teenage years, I guess it's probably okay. Is that what kind of message?
I was going to say one of the things I find the hardest in our clinic is particularly with teenagers, knowing when the right time, to suggest that they stop the carbimazole and have a go without, because, if they've been used to a regimen and they're doing well and they're coping fine and they don't have, any particular side effects, I feel quite uncomfortable sometimes asking them to have a try off, because actually, returning to their hypothyroid state just before their GCSEs or something, it can be really difficult, can't it?
Yes, it can.
So I think you're right. I think we've got better as well at trying to adjust the regimen to that individual person, and we use the lowest doses we can get away with now, really, don't we? So yeah, I mean, I think certainly if somebody's got anything important, either life events, exams, school coming up, we tend to just keep people stable now, don't we, if we can?
Yeah. Why change a winning formula?
Exactly.
This is the question, Claire. If you had a thyroid problem and you had to take thyroxine or carbimazole every day, how would you remember? How would you?
I would take it in the morning before my breakfast, and I would probably keep it beside my toothbrush or something like that. But I totally, having kids of my own, know that mornings can be absolutely manic in some households, and so what I tend to say to families is, yes, it's best to take it in the morning before you've had your breakfast, but if that's not going to happen and you can only do that 2 days out of 7, then it's much better to find a time of day that suits you and actually just consistently do that. So if you've got something in your daily routine that you always do, just keep your box of thyroxine tablets beside that, or your carbimazole or whatever, and you'll remember. And actually quite a lot of our teenagers coming into clinic now, take ownership themselves, and they've got their own dosette box in their room, and they just do it themselves, which is brilliant. And I always think, the sooner you can get, children to take control of their own illness, so they know the importance of taking it, I think they're far more likely to take it that way.
There's another question here, Claire, which is one that obviously, understandably crops up. It's the question of therapy with T3 as opposed to just T4. Do you have a particular view about that, or?
I mean, it's difficult, isn't it? Because you see so much in the papers, and you read about these things, and it's something that we just don't regularly use in our clinic, do we? I think it's hard, isn't it? Because free T4 is the driver, and levothyroxine in so many of these patients works so well. There isn't that evidence base for T3, and I know there have been some studies looking at it in combination, but I'm not convinced that the evidence is there to go to the hassle of adding in extra medications for children. I don't know, what do you think about this?
Yeah, because most of I take your point. People talk about the randomized trials in adults as adults, not children, and how, as a general rule, they've not shown any significant benefit of adding in T3. And people have, I think, quite rightly said, well, that doesn't, just because the trials to date haven't shown a role, doesn't automatically mean that there isn't a subgroup of individuals who will benefit from T3. I guess my take in young people is, and there's a certain purity about young people, before you get bogged down with all the stuff of life, the mortgages and what have you. And the vast majority of young people I managed with just T4 seem to be fine on it. And I say that because we've got people who have won Olympic medals on just T4. So if you can win Olympic medals just on thyroid hormone replacement, it can't be that bad, I would argue. And as I say, the young people, as a rule, come back with a smile on their face. They, as a general rule, they get the same kind of issues that other young people get. Sometimes they get tired in the same way that anybody gets tired, but usually there's an explanation for it. So I think that for the vast majority of young people, T4 seems to do the job pretty well. Yeah. But is it an area that needs further study? Yes, there may be there's still some unanswered questions, and I know of new trials that are focusing on this particular issue, but primarily in the adult population. When is the best time to, well, I guess, opt for definitive treatment? So this is, I guess, is thinking about your Graves' disease patient who's taken an antithyroid drug, and after a few years they stop it and the overactivity comes back. What's your approach to somebody in that situation? And because obviously the best time for definitive treatment, is that a good time, would you say, for definitive treatment? Or
yeah, so I'm just thinking back to a couple of patients I've had in clinic, recently, and interestingly, they sort of opted for completely different approaches to that. One of them had opted to have a trial off her medication between GCSEs and A-levels starting, and unfortunately, became hyperthyroid in the sort of the start of her second year of her sixth form studies. So she just said, nope, I'm not having this. I want my thyroid out well before, my mocks and my exams and things. And so she got it all over and done with, prior to Christmas time. And for her, that was definitely, the best decision. She didn't like the uncertainty of having her blood levels checked lots and tweaking up and down with her carbimazole and things. And then I've got another young lady who definitely didn't want surgery because it was too much of an upheaval in that last year. And so she wanted to go back on her carbimazole, which she'd been on already for 3 years. She knew it suited her. She knew how to run with it. So I think the key here is, asking the young person themselves. We can guide them, and thyroidectomy is, it's safe, it's well tolerated, it's a fairly simple procedure. Young people bounce back very quickly, but it is an invasive procedure, and some people might prefer just to stick to what they know. Go back onto their carbimazole. So the timing that's right for somebody might not be the right timing for others, and I guess that's the best way. I think the best way to look at it. I think we're very lucky in Newcastle. We've got brilliant thyroid surgeons, and if anybody is in this situation, I always just ask them to have a chat with the surgeons, because I think they're really good at, putting forward the balanced argument for both, for waiting or opting for definitive treatment there and then, and they can come up with their own choice.
And radioiodine?
So again, that's a fairly sort of similar idea. I think we have less people sort of taking that up. So I haven't had any examples recently that I can necessarily think of. But again, there are positives and negatives of waiting, aren't there, for that? So I don't think there's ever a right answer for these things per se.
I guess it goes back to what we were saying earlier on, doesn't it? Well, you've highlighted that, haven't you? It's personal choice, people knowing what the pros and cons are of each individual treatment modality. There's a question here about transition, and I guess there are 3 questions actually, but they kind of link together. At what age will my care move from my local hospital to GP? How can I best prepare for the transfer of care? What care can I expect from the GP? I was thinking that it's a little bit tricky, this one, isn't it? Because I know that you and I see a lot of primary healthcare teams. Well, I guess it's fair to say they're under a lot of pressure, as are hospitals. But what do you think about that transition? Any particular thoughts?
I think it very much depends on what thyroid condition you've got as well. For example, you run the teenage clinic here in Newcastle, don't you? But you would still see a lot of the Graves patients in that clinic as a sort of a transition service, because those ones can still be, needing quite intensive sort of, treatment changes and things, can't they? So that wouldn't be appropriate to go back to the GP. But somebody who's, finished growing, has been on a regular dose of, I don't know, levothyroxine for congenital hypothyroidism or something, and their dose hasn't changed since they've been 13 or 14, I would say that by the time they're, 16, 17, they're more than ready, and they're probably sick of us seeing us. They come into clinic every single time. We say, how are you? We're still fine. And, they don't want to trek to the hospital. So for them, moving to the GP, can't come too soon. And I think the key things I always try and prepare somebody for transition is, they need to take ownership of their condition. And I often say, you need your bloods checked, once a year, for example, for hypothyroidism. Try and time it around something that you can remember. So, treat yourself to a birthday present, go and get your bloods checked at the GP or something, and, just do it as a sort of routine thing. The only other thing, obviously, to point out here is, with pregnancy and young women, it's a bit awkward and embarrassing for the young people, but the parents tend to take it on board more, I think, because it's so far from the young person's mind at that point. But just a reminder that, in 10, 15 years' time, it will be high on their agenda, and to remember to take ownership and get their thyroid checked early in pregnancy as well. So I think those are the sort of two key tips I sort of talk about for transition, just taking ownership and, thinking ahead to the future to try and remember what information we gave them 15 years back.
I in my opinion, I think you've hit the nail on the head, really, and which is that in the olden days, I think there was a certain acceptance that the health service would contact you, but in 2024, I think there has to be some shared responsibility.
Definitely.
And I know it's in some respects, you could argue it's a bit of a shame that people don't get chased in the same kind of way, but I think things are less likely to get missed if it's a young person and their family working with a family doctor, with primary care, rather than just the primary healthcare team being expected to make the call every year, time for your thyroid function test.
And it's difficult when young people move as well. They go to different GPs with university and moving all over the place. So I do think, in this day and age, the system has changed and people do need to take ownership. And I quite often spend a large part of a clinic appointment, talking about that. I think it is important.
Under what circumstances do you think it's appropriate for someone to have more time during their exams, as a general rule?
Yeah, I think it is a really hard question to answer, because undoubtedly some people are more affected, aren't they, by fluctuating hormone levels than others. But to me, it's only fair if those people should have extra time and allowances, because potentially if they didn't have those changes in their thyroid hormone levels, they might not need that extra time. So it's really important that we're supportive, but at the same time, lots of people have very well controlled thyroid hormone levels and actually probably don't need that extra time. So again, it's one of these cases where it's on an individual level, isn't it? And I think the advantage that we have, and where we're very privileged, is we build up a relationship with our patients, don't we? A lot of these patients we see every 4 or 6 months for many years, and so the families are able to explain to us whether there are struggles or not. And so I think we'd be able to pinpoint the ones that we did think needed special dispensation, letters to school. I don't think it's just yes, you've got thyrotoxicosis, you need a letter, for example. But I think it's on a more individual level, isn't it?
When it comes to school performance, I think, or the impact of thyroid on your performance in the exam, whether you should have extra time, I think if you've been diagnosed relatively close to a set of exams, I think it's very likely that your ability to focus, concentrate will have been affected to a greater or lesser extent, and getting extra time is entirely reasonable. But I suppose most of the young people with thyroid problems that I personally see, they, once they're stable on their therapy, they're able to, in the vast majority of instances, concentrate in the same way as their peers. And so what they don't do is come to me saying, can I have a letter? Because they're thinking to themselves, well, I'm fine. I'm on the right medicine. My thyroid function tests are fine. Why should I have extra time given that my thyroid hormone levels are fine? My thyroid problem has been sorted. But as I say, I can certainly remember some young people who sadly have been really out of sorts for some considerable length of time leading up to exams. And in those circumstances, I think getting extra time and making sure those involved in the young person's education are aware of the background is so important.
Yeah, absolutely. Making school aware with plenty of as much notice as you can of the diagnosis is really important as well.
Yes.
Because the school teachers see them so regularly that they're often the ones who'll be able to pick up these things and flag them as well, aren't they?
Yes, that's quite so. What would be your message to young people who come and say, Doc, is this going to affect my quality of life, my ability to do what I want to in life in the long term?
I would absolutely hope not. I mean, Graves' disease, like we were talking about before, it can present challenges, but, looking to the longer term future, out with that initial period of uncertainty, there shouldn't be anything that anybody is stopped from doing by having a thyroid disease, whether it's an underactive or an overactive thyroid.
So really good news, I suppose.
Yeah, I think so.
Really good news. That's really every reason to be positive and upbeat. Something that's very, very dear to your heart at the moment, Claire, because I know this is something that you've been thinking about in great detail, is the ways of improving the outcome for young people with Graves' disease. And I think you've been involved in some research in this area for a little while, but you're planning some. Am I right in saying you're planning some?
Yeah. So I mean, it was obviously based on some research that you did, initially a couple of years ago, wasn't it? But we're 99.9% sure that we'll be able to run a study starting in the next year or so, looking at adding a single dose of a drug called rituximab into the standard treatment for people with Graves. And I think this is really exciting, obviously, because it's what I want to do, but also we're hopefully going to go from only about 1 in 4 people going into remission with Graves at the end of a sort of a 2-year treatment period to potentially up to half of those people. This could have a really big impact on we've just been talking about the challenges around school and knowing when to time definitive treatment, and none of these things a young person wants to have to think about if they don't have to. And what we're hoping is that by adding in this single dose of this extra antibody, that we can encourage the immune systems of a young person to go into remission, so that they wouldn't need to have that definitive treatment, or certainly be able to kick it down the line for later on, so they can get their important exams, etc., out the way. And we're planning it as a big multi-centre study all around the UK for anybody who's recently diagnosed with Graves. And there'll be lots of information available on the British Thyroid Foundation website, and it should be coming to clone the Fraser Centre near you, but hopefully this will be up and running in the next year or so. And it's really exciting, I think, for us as well, isn't it? There aren't very many clinical trials like this in the paediatric endocrine, the sort of children's hormone world. So this is quite exciting, I think. Yeah.
Where we are now represents a lot of hard work on your part, but I suppose one of the things that people ask about is rituximab, and it's for example, its safety record, but it's been around for a long time. And I suppose if you were recruiting somebody to the trial, then it's good for them to know that it has this really excellent safety record. Is that fair to say, do you think?
Yeah, absolutely. I mean, it's been used in other conditions like juvenile arthritis and some kidney conditions for a long time now. But also, when we look back to the data in the pilot study that you did, there weren't really any side effects during that study that were thought to be due to the rituximab at all. So, we found it to be really safe. And I always think that the acceptability of a drug is related to the fact that, nobody dropped out of that study that you did. Everyone chose to stay involved. To me, that says a lot about, the intervention that we're giving, that everyone was able to continue and wanted to continue in it.
Yeah. When you see young ladies in your clinic, if they were to ask you about their thyroid disorder and their, for example, chances of having children, what would you say to them?
I'd be able to be, very optimistic. There is no reason why they can't have children. And actually, I specifically mentioned the importance of getting the thyroid levels checked if they do become pregnant, which obviously, because this is a frequent occurrence. So no, I mean, I would say there is no reason why they should have any problems. Obviously, if, for example, they have Graves' disease and they're, having a relapse and, they're struggling with their thyroid function, then that's possibly going to make them slightly less likely at that point. But, a well-controlled thyroid condition shouldn't have any impact on fertility per se.
In this world where I guess it can seem a little bit daunting from time to time, living with a thyroid problem when your mates at school don't have it can presumably make you feel a little bit alone. And so if somebody came to you and said, I want to touch base with people who've been through what I've been through, who know about thyroid problems, then would you have any tips at all?
I think this is about the only time where I'd say, social media has advantages. There are lots of online support groups. The BTF will have the list on their website, but there are now lots of online chat forums, support groups, patient leaflets. I know that there are sort of webinars that are done. There are lots of different ways that these young people can get support. I know that some of these sort of prolific vloggers do things on TikTok. There are many ways that people can get information. The one thing I would say is I think it can be quite easy to go down a sort of a path that's not necessarily very helpful for these young people. Looking at sort of, for example, faddy diets and slightly strange,
right, okay.
Way out ideas. So I would tend to steer towards the reputable support forums and social media groups and things.
How do you know whether something's reputable or not then?
Well, I think anything run by the British Thyroid Foundation or recommended by them, or on any of the patient leaflets that we hand out, there'll be be available links and things. I would just stick to the more mainstream online support. But again, if you've got any queries or you're feeling like this, it's really important that you talk to your doctor about it, because they'll have, they may have other young people in clinic that they know would be happy to chat to people as well. Sort of peer-to-peer support. Friends at school might uncover other people, because there's, thyroid disease is common. There will be people in your school probably. It's just that you're not aware of them. So, always ask if you're feeling like that.
Do you think there is a thyroid diet? Is there something we have to be really careful about?
I mean, if you look online, I'm sure you'll find people willing to take your money to suggest specific thyroid diets. But I always just advocate, just eating a sensible, healthy, balanced diet. Making sure your vitamin D levels are normal, and that's the sort of thing we check in clinic anyway. But getting plenty of healthy food, sleep, sensible amount of exercise, everything in moderation. Don't you agree?
But there is this question about iodine, isn't there? And,
yeah.
And
true.
where do you? This is quite an interesting one, actually, isn't it? Because I know you and I have come across youngsters who have been on special diets.
Mm-hmm. Yeah.
Because for
other reasons.
For if you like, robust reasons, and diets that have been devoid of fish and dairy, and they have had relatively low iodine levels. And I suppose an awareness of the foodstuffs you get iodine from, as I say, fish and dairy, is quite important, because I think you can get iodine supplements, can't you? You can get them.
That's something that your doctor would always be able to give you advice on if you asked them, if you weren't sure about, isn't it?
Yeah, that's a good point, actually. Yeah, so if in doubt, have a chat to your GP, because they could directly.
I would hate people to waste lots of money on these things that there isn't much evidence for, when it would be actually much better just having a diet that's sensible and rich in fruit and veg and things.
So healthy diet, but maybe have a chat to GP if you're, for various reasons, don't have fish and dairy.
Yeah, that seems reasonable.
Okay.